After studying this module, you shall be able to know the signs and symptoms of bipolar disorder, learn about the epidemiology of bipolar disorder, identify the etiological causes of bipolar disorder, and also analyze the various treatment approaches to bipolar disorder. Introduction. Bipolar disorder is one of the variant of forms of the broad category of mood disorders. Bipolar disorder is a psychological condition characterized by alternate episodes of extreme emotional experience of depression or mania or both. Though the features are varied, the distinguishing feature is an experience of excessive mood that distorts reality and the way the person thinks or functions. This is often accompanied by changes in activity and movement, energy levels, sleep patterns, appetite, and eating patterns and motivation. Bipolar disorder is also known as manic depressive disorder or manic depression or bipolar affective disorder. The distress caused due to this illness can lead to anxiety, poor job functioning, disrupted relationships, in some cases drive the person to commit suicide. But bipolar disorder can be treated and people with this disorder can lead fulfilled lives with the aid of medicines and ongoing therapies. In clinical picture, to understand signs and symptoms, we must learn first about depressive episodes. Depression is a mood state lasting only a few hours or maybe a few days, but not necessarily causing impairment in a person's functioning. Though there are different subtypes of depression that come under unipolar depression. Bipolar disorder is characterized by major depressive episode. According to DSM 4 criteria for a major depressive episode are as follows. The person must experience a depressed or irritable mood or a loss of interest or pleasure in most or all activities for a minimum of 2 weeks. The person must experience at least 4 of the following criterion symptoms for 2 weeks, which are appetite disturbances, which may include either loss of appetite or overeating, body weight change associated with appetite, disturbance in sleeping patterns, which may include insomnia or hypersomnia, psychomotor agitation or retardation, decreased energy, feeling of triviality or extreme or inappropriate guilt, difficulty in thinking and concentrating, recurrent thoughts of death or suicide or attempting suicide. The feelings of sadness, guilt, hopelessness, anger, etc. are experienced by a person during a major depressive phase, which are not temporary but rather exist for a long period of time. The person may experience bouts of sadness at different times during the day and almost every day for the week. These symptoms are persistent and cause remarkable impairment or distress in daily functioning, jobs and relationships. The person may withdraw from activities or hobbies which she or he may have previously enjoyed. Then we have to understand manic episodes. Mania refers to a long period of feeling high, overly happy or excitable. According to DSM-4, a manic episode includes a distinct period of abnormally and persistently elevated, expensive or irritable mood that lasts at least 1 week or less if hospitalization is necessary. 2. 3 or more associated symptoms such as inflated self-esteem or grandiosity, decreased need for sleep, pressured speech, racing thoughts, distractibility, increased involvement in goal-directed activity, psychomotor agitation, and excessive involvement in the pleasurable but potentially harmful activities. Severity of disturbance sufficient to impair occupational, social, interpersonal or personal functioning or to necessitate hospitalization to prevent harm to self or others is a defining criterion. Behaviors exhibited during this period are characterized by impulsivity. The noticeable feature of mania also includes talking incessantly, being euphoric, being overly workaholic and enthusiastic about new projects, yet lacking the concentration to implement them, not being tired or sleepy. The cognitive symptoms include both psychotic and non-psychotic symptoms. Psychotic symptoms of delusions, hallucinations that may be mood congruent, that is, delusions or hallucinations with content consistent with the elevated mood. Or these hallucinations and delusions may be mood incongruent. As a result, they may feel out of control and engage in violent or destructive behaviors, which necessitate the need for hospitalization. Non-psychotic symptoms include a flight of ideas experienced as racing thoughts, lack of concentration, distractibility, confusion and occasionally disorientation. A defining criterion is whether the severity of the symptoms is sufficient to cause social and occupational impairment or needs hospitalization. If untreated, the manic episode can go on for 3 to 6 months. Hypomanic episodes. Hypomania is a milder form of mania. The criteria for hypomania is described by DSM is as follows. 1. A distinct period of abnormally and persistently elevated or expensive or irritable mood lasting at least 4 days with associated symptoms found in mania. 2. Absence of psychotic symptoms like delusions and without symptoms severe enough to cause occupational or social impairment or hospitalization. 3. The hypomanic episode must be distinctly different from the person's usual non-depressed mood and must be clear change in functioning. The hypomanic episode is actually experienced as enjoyable and interpreted by the patient as a general sense of well-being. They experience increased physical energy or decreased need for sleep that can actually lead to high productivity and increase in fluidity and creativity. Bipolar disorder is found at higher than chance levels among particularly creative people. The person often denies any problem and thus does not seek treatment. Then we have mixed affective episodes. According to DSM IV, it consists of at least one major depressive episode and a manic episode lasting almost every day during 1 week period. It includes rapidly alternating moods that may include sadness to irritability to euphoria, accompanied by symptoms of a manic episode and a major depressive episode. The symptom must often include insomnia, agitation, appetite disturbances, suicidal tendencies, and psychotic features. Patient may have grandiose thoughts or slow impulsive behavior and may show symptoms of guilt or anxiety at the same time. According to DSM V, a new specifier with mixed feature has been added that can be applied to episodes of mania or hypomania when depressive features are present and to episodes of depression in the context of major depressive disorder or bipolar disorder when features of mania or hypomania are present. A mixed episode is a severe form of the bipolar disorder and causes significant functional impairment. Now we must understand about the diagnosis of bipolar disorder. So we have diagnostic subgroups of bipolar disorder. The different subtypes of bipolar disorder are considered part of bipolar spectrum disorder. In the DSM system, the history of current and past episodes is taken into consideration for the purpose of diagnosis. In DSM-IV, substantial changes have been made in the bipolar disorder section. Bipolar disorder is now clearly separated into different subtypes, where we have bipolar 1 and bipolar 2 disorders majorly. In bipolar 1, the person experiences one or more manic or mixed episodes, usually accompanied by one or more major depressive episodes. DSM-IV has further categorized bipolar 1 based on the most recent episode. Bipolar 1 most recent episode hypomanic requires at least one major depressive episode and a current or most recent hypomanic episode. In bipolar 1 most recent episode manic requires at least one major depressive episode and a most recent manic episode. In bipolar 1 most recent episode unspecified, there should be at least one manic or mixed episode and a current manic or mixed or hypomanic or major depressive episode that has not met the full duration criteria at the time of diagnosis. Patient with bipolar 1 experience the highest levels of elevated mood. Bipolar 2, the individual must have had at least one hypomanic episode but not manic or mixed episode. That should last minimum of 4 days and one or more major depressive episode. Bipolar 2 is generally taken as less severe form of bipolar disorder. However, the cumulative effect is no less than that of bipolar 1. Bipolar 2 has a more chronic course, is associated with greater episode frequency, comorbidity, suicidal tendency and a longer depressive episode. It is also difficult to diagnose due to the presence of hypomanic episode which does not actually cause functional impairment. The predominant polarity of bipolar 2 is depression, thus gives an idea as to why the suicidal rates are high. Bipolar 2 is not mentioned in ICD-10. Then we have another category named as bipolar not otherwise specified. This is diagnosed when it does not fall under any of the categories if a person displays some symptoms of bipolar disorder but not others. The clinicians may diagnose bipolar not otherwise specified. The diagnosis of bipolar NOS or not otherwise specified is indicated when there is a rapid change between manic and depressive episodes and can also include recurring episodes of hypomania. Bipolar NOS may be diagnosed when it is difficult to tell whether bipolar is the primary disorder due to another general medical condition such as substance abuse. Then we have another category named as cyclothymia. Cyclothymia is a chronic mood disturbance persistent for at least 2 years, though criteria says 1 year for children and adolescents. That involves numerous hypomanic episodes and numerous periods of depressed mood of insufficient severity and duration to meet criteria for major depressive or major manic episode. It is often considered as a mild form of bipolar disorder with less or no functional impairment in social and occupational areas. Another criteria given by DSM V is that during the 2 years period, the hypomanic and depressive episode have been present for at least half the time and the individual has not been symptom free for more than 2 months. Rapid cycling bipolar disorder. Cyclicity refers to the length of time between the episodes. It can range from less than 48 hours to many years, thus showing considerable intra-individual variations and much greater inter-individual variation. Among 13 to 20% of the bipolar patients are categorized as rapid cycling patients, described by Goodwin and Jemison in 1990. According to DSM-4 criteria, the patient must experience at least 4 distinct episodes per year. Thus, the person experiences rapidly changing mood swings with severe irritability, impulsivity, anger bursts, etc. The episodes follow a random pattern and do not occur in regular cycles. This has been found to be more common in females. It's been defined another extreme or rare form known as ultra rapid cycling with 4 mood episodes within a month. Some rare cases also show several mood switches during the day on several days during the week and are termed as ultra-dyne cycling patients. For most cases, rapid cycling develops later in the course of the disorder. Now there are certain changes in the diagnostic subgroups in DSM-5. For bipolar 2 disorder, DSM-4 had excluded the criteria describing change from depression to hypomania under antidepressant treatment. In DSM-5, it has been changed as the explicit criteria, provided it persists fully at the syndromal level beyond the physiological effect of the drug. Other specified bipolar and related disorders. The not so well defined group bipolar NOS in DSM-5 has been replaced with other specified bipolar and related disorders. This diagnosis takes into account people who have experienced depression before and currently meet all the criteria for hypomania except the duration. Also, if the person has too few symptoms to meet bipolar 2 criteria but has been symptomatic for more than 4 days may fall in this category. Difficulties in diagnosing. Different comorbid conditions make the diagnosis of bipolar disorder difficult. Goodwin and Gahemi in 1999 noted that almost 40% of the hospitalization cases that they had diagnosed as bipolar had been misdiagnosed before. Often the acute and first depressive episode of the bipolar disorder are misdiagnosed to be unipolar. Hypomania is particularly difficult to distinguish from normal joy to euphoria. Severe psychotic symptoms of grandiosity and hallucinations may be misconstrued as schizophrenia. Features of substance abuse may make it difficult to recognize bipolar disorder. This is one of the most problematic conditions. Since this feature is pretty widespread, and apart from making diagnosis difficult, it is also associated with worst outcomes as they interfere with the treatment adherence and affect brain processes at the neuronal level. Personality disorders are another category of comorbid conditions. Studies have found particularly high rates of cluster B disorders among bipolar patients. Such cases often face greater maladjustment problems and the course of the disorder is relatively more difficult. Epidemiology of bipolar disorder. Epidemiology is defined as a study of the distribution and determinants of diseases in human population. Two major epidemiological studies are the Epidemiologic Catchment Area Study and National Comorbidity Study. Prevalence rates. The rate of bipolar 1 disorder is generally about 1% of the population and 82.9% of the diagnosed cases falling in the severe category. 12 months prevalence was found to be 2.6% of the adult population, while the National Comorbidity Survey reported a rate of 1.6%. Bipolar 2 disorder is estimated to affect somewhere between 0.3 and 3% of the population, and bipolar spectrum disorders, depending on how defined, they may affect between 3.0 and 6.5%. Sex differences. Epidemiologic studies suggest that bipolar 1 is almost equally common in men and women. Bipolar 1 disorder occurs approximately equally in both genders, and bipolar 2 may be more commonly seen in women. Rapid cycling is more common and severe among female population. Age of onset. A survey of the empirical literature indicates reliable major differences between the age of the first onset of bipolar disorders. Considering hospital admissions as a criterion, most bipolar first admissions occur between ages 20 and 29 years. Data from the 5 sites of the NIMH Epidemiologic Catchment Area Program reveals a median age of onset 19 years for bipolar disorder. Differences between urban and rural settings. The findings so far have been inconclusive, though data from 3 ECA sites have shown non-significant increase of the incidence of mood disorders in urban areas compared to rural, which indicated the possibility of higher prevalence rates of mood disorders in urban areas, but such differences may involve interaction among the region, migration pattern, socioeconomic status, lifestyle, environment and other related variables. Many studies reported higher rates of bipolar disorder in white than black people, but the ECA program report no significant difference between blacks and whites. Socioeconomic status differences. Data suggests a higher incidence of bipolar disorder among upper and possibly middle class individuals. NCS data in contrast shows that rates of all psychiatric disorders decline steadily with income and education. Cross-cultural differences. United States had the highest lifetime and 12-month prevalence of bipolar spectrum disorders, while India had the lowest. Exceptions were found for Japan, a high-income country with very low lifetime and 12-month prevalence of bipolar spectrum, and Colombia, a low-income country with high lifetime prevalence of bipolar spectrum. Etiological approaches. In order to understand the emergence of the bipolar disorder, we have certain approaches, number one of which are biological approaches, wherein we discuss genetics. Genetic factors have been hypothesized to be responsible for mood disorders, particularly bipolar disorders. The studies used to investigate are of four types: family studies, twin concordance studies, adoption studies, and mode of transmission studies. Family studies. Higher frequency of mood disorders occur among relatives of bipolar probands as compared to unipolar probands. The number incidences that have been reported among first degree relatives are approximately 12 to 22%. Family pedigrees also show a significantly higher incidence, which is approximately 11% of bipolar disorders. Also, unipolar depression is more common in relatives of bipolar subjects, whereas relatives of unipolar depressive rarely show bipolar disorders. Twin studies. These studies show that monozygotic or identical twins are more likely to have mood disorders in common than fraternal or dizygotic twins, thus indicating a strong genetic contribution to vulnerability. A review of twin literature showed concurrence of bipolar disorder in 72% of patients who are monozygotic twins as opposed to 14% of the dizygotic twins. Adoption studies. It has been found that significantly more biological parents have bipolar disorders, 31%, as opposed to 12% of adoptive parents, though this study has not been verified by any other credible research. Mode of transmission studies. There is high probability of polygenic transmission of bipolar disorders. Lower father-son concurrence indicates an X-linked gene transmission. Some linkage studies point at chromosome 11. Neuroendocrinological causes. The monoamine theories focus on deficiencies of neurochemical system that focus on catecholamine, norepinephrine, serotonin, and dopamine. Conversely, mania is said to be caused due to excess of neurotransmitters. Other researchers also point at additional neurotransmitters like acetylcholine and gamma-aminobutyric acid as being dysfunctional and hence causing depression, while excess of it may cause mania-like symptoms. So, the fluctuation between excess and deficiency of the neurotransmitters may play a major role. Environmental perspective. Stress diathesis hypothesis suggests that stress along with the biological predisposition is likely to precede episodes of the disorder. Life events appear to trigger the onset. A life event may trigger a mood episode in a person with genetic disposition of bipolar disorder. Even without clear genetic factors, altered health habits, alcohol or drug abuse, or hormonal problems can trigger an episode. Good social support acts as a mitigating factor in case of difficult life events. Family atmosphere also has a role to play. In some cases, highly conflicting and criticizing family members increase the probability of relapse. Psychological perspectives. There are various theories which describe the processes involved in the onset of the disorder as well as propound a way of treatment. First, we have psychodynamic approach. According to Freud, depression results due to loss of an unconscious object, thus leading to anger and reproach becoming self-directed. Mania results when the conflict is the same but the energy is channeled outward. The manic phase would occur as the ego tries to defend itself against its aggression by using denial-based defense mechanism. This might account for the exaggerated self-esteem and grandiose delusions of manic patient. In order to protect themselves from the feelings of worthlessness, the ego invents a fantasy wherein the person is more successful or powerful than they really are. Abraham in 1949 speculated that mania represents a failure or the defense mechanism of repression to restrict self-hatred and self-guilt arising from the need to give up sexual gratification without gratification. Some researchers emphasized on the failure to internalize standards as a reason for depression. Individuals who fail to meet their unrealistically high standards are also prone to depression. Behavioral approach. According to behaviorists, cause of the disorder is disruption of the response reinforcement relationship. Charles and Fester in 1973 asserted that the depression is generalized reduction of rates of response to external stimuli. He drew analogies with the process of extinction, how major losses in life happen due to losses of important sources of reinforcement. Then we have learned helplessness theory. Martin Seligman's theory hypothesized that depressed individuals habitually attribute negative outcomes to internal, stable and global causes, whereas positive outcomes to the external, unstable and specific causes. Thus, the person does not take any credit for success and attributes it to fate or any other external factor. However, according to Alloy, Clements and Colden, attributional style is only a risk factor and not a causative factor. Seligman's model also does not differentiate between unipolar and bipolar depression with regard to attributional style. However, some studies indicate that attributional styles are not significantly different for unipolar and bipolar patients. Cognitive theory. Aaron T. Beck developed a cognitive theory that initially focused on depression. He asserts that the essential elements of the bipolar disorder are in the form of cognitive triad of dysfunctional thought patterns. While manic states occur as the patient denies certain aspects of reality in order to promote or preserve an unrealistic set of self-perceptions without person's direct awareness. And the manic mood state is a superficial one that serves to cover up the underlying depressed thinking. Bipolar patients also voice more hopelessness and have more suicidal thoughts than clinically normal controls. Treatment of bipolar disorder. We have various treatment modalities available for bipolar disorder. First is biological treatment, or we can call it pharmacological treatment also. Bipolar disorder is also a major risk factor for suicide, and medication generally leads to side effects. For its effective treatment, correct diagnosis is imperative. Bipolar disorder is commonly treated with mood stabilizers such as lithium, anticonvulsants like Devalprex, sodium. Sometimes it is accompanied by administration of antipsychotics and antidepressants. Atypical antipsychotic medications like olanzapine, ziprasidone, etc. are used to treat psychotic symptoms that accompany mania. Antidepressants like fluoxetine, paroxetine, or sertraline are used to treat depressive episodes. To prevent rapid switch from depression to mania, patients are administered a combination of mood stabilizers or antipsychotic drugs with the antidepressant. ECT or electroconvulsive therapy may be used to treat the manic or depressive phase of bipolar disorder. ECT uses an electrical current to cause brief seizures while the individual is under anesthesia. This is considered the most effective non-drug treatment for bipolar disorder, though nowadays it is considered as the treatment of choice. Transcranial magnetic stimulation, that is TMS, uses high frequency magnetic pulses to target affected areas of the brain. This treatment is used more commonly than ECT. Psychodynamic approaches to treatment of bipolar disorder. This involves psychoanalysis with an intense, open-ended, uncensored exploration of the person's deepest desires, which may have been pushed into the unconscious. Results of the study by Gallagher, Thompson and Stephen in 1994 found that brief dynamic therapy is effective in treating depressed family caregivers. Behavioral approach. The therapeutic approach is based on the causes of loss of reinforcement. Initially, the therapy process was matched to primary deficit faced by the depressed individual. Later, cognitive models were also developed that found that use of all three kinds of modules, that is, activity increases, interpersonal and cognitive, were helpful in relieving the person regardless of their individual deficits. Levinson also suggested that increased self-awareness can mediate between reduced reinforcement and depression. Learned helplessness theory. No therapy program has been actually developed from this perspective, but 4 basic strategies have been outlined by Seligman. 1. The environment should be manipulated such that it promotes recovery, re-establishment of a sense of control over daily life. 2. Skill training to help the person actualize increased ability to control the environment. 3. To help patients replace unrealistic goals with the realistic goals by giving a resignation training. 4. Modifying the attributional style to avoid recurrence of depressive episodes. Cognitive behavior therapy. Cognitive therapy is aimed to identify irrational automatic thoughts and the underlying assumptions and challenge them. The patients are taught to identify and examine their distorted thoughts and perform a reality check to make them accurate. Thus, they gain coping strategies while improving skills of awareness, introspection, and evaluation. Though there is no cure for bipolar disorder, but treatment works for many people. Treatment works best when it is continued rather than on and off. However, mood changes can happen even when there is no break in the treatment. Patients should be open with their doctors about the treatment. Talking about how treatment is working can be helpful and more effective. It may be helpful for people or their family members to keep a daily chart of mood symptoms, treatments, sleep patterns, and life events. This chart can help patients and doctors track the illness. Doctors can use the chart to treat the illness most effectively. Summary of the chapter. Bipolar disorder is one of the variant or form of the broad category of mood disorders. It is a serious mental condition that is characterized by extremities of mood. The signs and symptoms are characterized by depressive episodes, manic episodes, hypomanic episodes, or mixed affective episodes. For diagnostic purposes, there are various subtypes of bipolar disorder: bipolar 1, bipolar 2, bipolar NOS, and cyclothymia. Bipolar disorder has been most often attributed to genetics, but psychological approaches also exist. There is no cure for bipolar disorder. However, it can be effectively managed with the help of treatment and psychotherapy. Patients can lead fulfilling lives even with this disease.